Interventions with a King. Discussion and commentary based on articles from JACC, Cardiovascular Interventions.
I'm Spencer King, editor of JACC Intervention. We're having a wonderful conversation this afternoon with Dr. Takashi Kimura from Kyoto, Japan, and Dr. Shinichi Shirai from Kokura, Japan. They have put together an interesting study. Dr. Kimura has been involved for a long time with the Japanese registry, who's carefully collecting information on these patients. And Dr. Kimura, perhaps you can introduce the trial, and then we will like to hear some of the results. What were you after with this registry?
Yeah, actually we started this real-world registry in year 2004. At that time, the JCypher stent was introduced in Japan, and we invited 37 centers in Japan and collected data in 15,000 patients, consecutive patients undergoing JCypher stent implantation. So we did make several. We tried to capture prospectively to some of the important aspects of PCI, such as antiplatelet therapy or surgical procedure during follow-up. So we have now 3-year follow-up of this registry.
So this cohort that you were studying and this question you were studying is a fascinating paper that will be, by the way, in the December issue of JACC Intervention. Dr. Shirai, yes. You were studying, as I remember it, the length of stenting and the multiple stenting. What did you find in your registry relative to stent length?
Yeah, for lesion level data, long stent is not absolutely risk of thrombosis, but TLR is increasing by stent lengths. And per patient data, the longest cohort of stent lengths is increasing in stent thrombosis up to 3 years, and TLR rate is increasing according to the stent ranks. But the death and MI rate was not statistically significant among groups after adjustment for baseline characteristics.
So how did you control for the baseline degree of stenosis? We might think that the stent length would be determined by how extensive the disease is, but you corrected for that. Is that correct?
By propensity, I corrected it.
Yeah, we did a propensity score analysis and corrected those data with such as lesion length and vessel size, something like that.
I think the listeners would be interested to know in Japan how you perform this registry work, because keeping up with patients, as we all know, is very challenging. Mm-hmm. How is it done, and how successful are you in getting complete follow-up?
Actually, we have a 97% rate of follow-up at 1 year. Roughly 50 to 60% of patients came back to the original hospital that PCI was performed, and for the other 40% of patients, we did contact by telephone.
Yeah, and if they are to make sure you've captured all of the deaths and hard endpoints, do you have a national registry that you can
Unfortunately,
access?
it's not available in Japan, so that is a big problem for the Japanese clinical research.
Right. Well, let me say, using this data, what is the current recommendation? How are you using this to influence the application of stenting in your patients? Do you limit the length of stent intentionally?
I think for the treatment of single lesion, I still believe the stenting from non-healthy to healthy segment is preferable because the residual dissection or some residual stenosis at the edge segment is clearly prone to restenosis or stent thrombosis. So, and also in this in the current study, we did not see any significant difference in terms of stent thrombosis with increasing stent length. So, but for the multiple stent implantation for multi-vessel disease, clearly increase the rate of target region revascularization, and this is consistent with the finding in the syntax data. So we are doing very aggressively performing PCI, but in the extreme case, who requires multiple long stent, probably surgery will be a very good alternative for PCI.
So, and we learned many things from the FAME trial that perhaps we should, of course, stent things that need to be stented and not just apply long stents for no good reason. This is real fascinating. I think it's very helpful for us in thinking about how to plan our interventions. Dr. Shirai and Dr. Kimura, thank you so much for visiting with us, and thank you for your help on our editorial board as well. For JACC Interventions, hope you've enjoyed this.